Good morning. Thank you, sir, for that kind words of introduction. And I must thank KSM and the SLC, Sri Lankan College of Endocrinologists, for giving me this opportunity to discuss about this guideline-based management of diabetic emergencies. I'm sure that all of you must have seen at least one patient with these diabetic emergencies in your careers. So I invite you to remember one of those patients and go through this presentation, go through this talk, and think what you have done correctly and what you could do better and what you would do in the future for the better management of the patient. So, since this is a guideline-based management of diabetic emergencies, I selected two guidelines. That is one joint British JBDS, Joint British Diabetes Society guideline for adults mainly, and ISPAD for mainly for pediatric and adolescent diabetic ketoacidosis and HHS management. So, in next 20 to 30 minutes, I will be discussing two hyperglycemic emergencies. That is, one is diabetic ketoacidosis. The second one is hyposmolar hyperglycemic state, which some of you may know that previous terminology on hyposmolar non-ketotic coma, but newer terminology is hyposmolar hyperglycemic state. And then euglycemic emergency, one that you may get the patient in future, because with the introduction of SGLT2 inhibitors into our diabetic medication regime, you may get patient with this euglycemic diabetic ketoacidosis as well. And third one is, as well as this hyper and euglycemic emergencies, hypoglycemia. That I'm sure that some of you may be experiencing it at the moment also. So by the end of the lecture, if I am not dragging it too much, I hope that I won't also get hypoglycemia. And then first I will be discussing about these hyperglycemic emergencies, diabetic ketoacidosis and hyperglycemic hyposmolar state. I'll go through the pathophysiology of those two conditions. Before going to that, I would like to discuss about this absolute versus relative insulin deficiency. That the terms that you should know when you are discussing about the pathophysiology of this disease. So if the y-axis is the amount of insulin that you have in your body, the lowest one is when you have this absolute insulin deficiency, like in type 1 diabetes and beta cell failures. So you don't have that much of insulin in your body. The insulin level that you have in your body is lower than the level which is needed to inhibit the ketogenesis, and it is lower than the level that is needed to inhibit the gluconeogenesis and glycogenolysis as well. So at that absolute insulin deficiency state, you will get both ketogenesis and gluconeogenesis. But there are conditions like in type 2 diabetes, you have only relative insulin deficiency, because you have insulin but your insulin can't work, and you don't have enough insulin to work to inhibit gluconeogenesis and to inhibit glycogenolysis. But you have that level above the level that is needed to inhibit the ketogenesis. So in that entity, you don't get a ketogenesis, but you get a gluconeogenesis and glycogenolysis. So with that background information, you can explain this pathophysiology of diabetic ketoacidosis and this hyposmolar hyperglycemia syndrome or hyposmolar hyperglycemic state. So first, in diabetic ketoacidosis, there's you get in type 1 patients, but in prolonged type 2 diabetic ketoacidosis as well as the other types of diabetic patients, you get this diabetic ketoacidosis when there's absolute insulin deficiencies there. But on top of that, when we get the patients might have these precipitants, which might have caused this counter-regulatory anti-insulin hormones like glucagon, cortisol, this adrenaline, noradrenaline, all those anti-insulin hormones that which was discussed earlier also, those are increased, and the absolute insulin deficiency is also there. So these two metabolic pathways are activated. One is this gluconeogenic genetic enzymes are increased, then increased liver gluconeogenesis, that is more glucose production in the liver, and glycogenolysis, the glycogen which is stored and then they are broken down into glucose, and reduced glucose utilization, which causes hyperglycemia, osmotic diuresis and dehydration and electrolyte abnormalities. But more than that, that process will take some time to develop. In these patients, because of this absolute insulin deficiency, they will have this marked activation of hormone sensitive lipase, which is there in adipose tissue. So it will break down the stored lipid into free fatty acids. Then they are transported into the liver. In the liver, from free fatty acids, because of the insulin, because insulin level is not there to inhibit ketogenesis, there's increased production of ketone bodies, which causes acidosis, and that will present earlier than the symptoms of this hyperglycemia, this dehydration and electrolyte abnormalities. So in those patients, the ketogenesis is predominant and they present as diabetic ketoacidosis. The second part, there's a relative insulin deficiency in the presence of increased counter-regulatory hormones. So out of those two pathways, since this insulin level is relatively low, not absolutely low, it will inhibit the ketogenesis. So absolute or minimal ketogenesis is there, that is not prominent. But since there's gluconeogenic pathways, glycogenolysis and glucose utilization is reduced, marked hyperglycemia is there, which will develop over days, and then significant osmotic diuresis with high glucose level, and then which can cause electrolyte abnormalities and severe dehydration, which will eventually cause hyposmolarity. That's why the term hyposmolar hyperglycemia syndrome comes. In earlier terminology, that is why non-ketotic coma, non-ketotic part was there, because ketogenesis is not there. But in some cases, there may be a low level of ketogenesis, which is not as high as in diabetic ketoacidosis. So what are these ketone bodies? This is the beta oxidation pathway. From the free fatty acids, they are broken down via beta oxidation, and ultimately they will form acetoacetate, that is one of the ketone bodies, and then the beta hydroxybutyrate, that is one of the other ketone bodies. They will cause acidosis and ketosis. And the other important thing is thing to remember here, the ketogenesis, even it's stopped at some point, the acetoacetate will continue to transform into beta hydroxybutyrate. So in some patients, even though ketogenesis stops, beta hydroxybutyrate may be there in your blood. So that I'll discuss later will be a resolution pitfall in your diagnosis. So I discuss about the precipitant that will increase the counter-regulatory hormones and which will push the patients into these emergencies. So one, you can remember those with 7 I's. One is insulin deficiency or insufficiency. If the patient was taking insulin, whether he was not taking for the past few days, whether he reduced the dose, or if the patient present to you in the first instance, like in type 1 diabetic patients, 25% of those patients will come with diabetic ketoacidosis. So in those patients, the insulin deficiency or insufficiency might have triggered this, precipitated this diabetic, mainly diabetic ketoacidosis. The other one is iatrogenic causes, which we usually interfere with the patient's metabolism. We give steroids, thiazides, sometimes atypical antipsychotic drugs, and then we push the patient to a state where patient can't tolerate or patient can't adjust to that stress. And the commonest cause for both these conditions are infections, mainly respiratory and urinary tract infections, and the other gut or food ischemia and infarctions, acute coronary or stroke, and severe inflammatory conditions like acute pancreatitis and acute cholecystitis or any other severe inflammatory conditions. And the other ones are alcohol and cocaine. So clinical presentation wise, the basic things that you have to understand in diabetic ketoacidosis and small hyperglycemic state is they are bit similar, but also there are some differences. So in diabetic ketoacidosis, because the ketosis is bit rapid to develop, so they develop this over hours to days. And there's a failure in your background history. If you are taking the history, the patient may have missed some insulin doses, or there may be a background infection history. So patient will come with osmotic symptoms because of this hyperglycemia, and then there's acidosis. So patient is comes with nausea, vomiting, and anorexia, with loss of appetite, abdominal pain. Sometimes it may mimic an acute abdomen as well, and generalized fatigability, rapid weight loss, especially in newly onset type 1 diabetes, that indicates that catabolic states where the insulin level is low. And late features are patients are really dehydrated, dry, and then comes with some uh, this dehydration, that hypovolemic symptoms as well. And at the end of the presentation, patients might have this altered mental states as well. In hyposmolar hyperglycemic state, there's, as I explained earlier, more than ketosis, there's profound dehydration which might have developed over days, especially in elderly patients who are taking these drugs and they have missed the drugs, and then high sugar levels which have caused dehydration with osmotic diuresis, and the patients not taking adequate oral intake, then they get profound dehydration, and the presentation is basically due to this dehydration. It can cause unwellness for days to weeks, and with preceding illness like immobility, dementia, limiting their oral drug intake and the fluid intake, and the osmotic symptoms. Uncommon ones are this abdominal pain, but they can have these neurological symptoms like seizures and reduced conscious level. So diagnosis, there are several guidelines and several societies that has come up with diagnostic criteria. I will just focus on the middle one, JBDS criteria. So in that, you have to have this, like the name itself says, you have to have diabetes, that is hyperglycemia, ketosis, and acidosis. So diabetes is the plasma glucose level more than 200. So milligrams per deciliter. If you are going by millimoles per liter, it should be more than 11. And then the ketosis is defined as if ketones are measured, beta hydroxybutyric levels, butyrate levels, those should be more than or equal to 3 millimoles per liter. And the acidosis is defined as pH less than 7.3 or bicarbonate less than 50. So this is subdivided into mild, moderate, severe. In severe cases, you may have to have the ICU due care. But for the time being, the cutoff you have to remember: glucose 200, pH 7.3, bicarbonate 15, and ketones more than 3. Like I said, when you are suspecting a patient with diabetic ketoacidosis and you check blood sugar, it's more than 200, then check for the other two to diagnose diabetic ketoacidosis. If those are not there, then you may be dealing with something else. All the three must be there to diagnose as diabetic ketoacidosis. Then the other one, small hyperglycemic state. In that one also we will go with UK guideline, and in that the demarcating feature is there is no ketosis, so the blood beta hydroxybutyric acid level is less than 3, and pH is more than 7.3, there is no acidosis, and bicarbonate is more than 15, there is no acidosis. The differentiating thing is blood sugars are very high, more than 30, that is 540 milligrams per deciliter, and the osmolality you have to check it on the admission. Then if the blood sugars are more than 540, the patient is dehydrated, it's always better to go for serum osmolality. And then if it's more than 320, milliosmoles per kilogram, that diagnose in the exclusion of ketosis and acidosis, that concludes the diagnosis of HHS. So then I'll go to the management of diabetic ketoacidosis and HHS. In managing the patient, only you have to go for these objectives. If you achieve these objectives, then you are okay with the management. So I'll go through the management of diabetic ketoacidosis and HHS in adults first, and then go for the changes in pediatric population. So first thing that you have to think of the correction of dehydration. That is important even in diabetic ketoacidosis and HHS. Then the second thing is correction of hyperglycemia, both in DKA and HHS, and ketoacidosis, which is only relevant in diabetic ketoacidosis. And correction of electrolyte abnormalities is also important in both conditions, as well as the other 4 and 5. That's also that must be also managed at the same time, precipitating factors and complications. So the management protocol is quite large. I'll break it down, and I have break it down to a simple version. So my thinking pattern when I come across a patient with diabetic ketoacidosis is the patient's management can be divided into time frames. First hour, then first hour to 6 hours, 6 hours to 12 hours, and 12 hours to 24 hours first day. And then initially when I come across a patient, as we all know in emergencies, we have to go through this ABCDE protocol assessment: airway, breathing, circulation, and disabilities and exposure. And then at the same time we have to do investigation which is needed for the diagnosis of the condition, as well as for the etiological or precipitant factors which might have caused this condition. Then in the management part, throughout the management, we have to think of these three management chunks, whether we have managed it adequately or not. That is, one is fluid, the other one is insulin, the other one is electrolyte, mainly potassium. And the next thing, throughout the management, we can't leave the patient without monitoring. So hourly blood sugar monitoring, ketones if you have bedside ketone meters. Otherwise, you may have to monitor it via urine or serum ketone body assessment, and input output. Then 2 hourly, some guidelines says 2 hour to measure 2 hourly, but sometimes it may be difficult. So I have mentioned as 2 at the end of second hour, 4th hour, 6th hour, 8th hour, and 24th hour. Check VBG for potassium, bicarbonate, and pH. ABG is not actually necessary in this case because there's only slight difference between bicarb and pH in ABGs and VBGs. That will not affect the overall management of this condition. So VBG is enough. And from the first hour onwards until 12 hours, you have to reassess your goals, whether you have achieved your goals. I'll discuss about your goals, and then you may need to change your fluid type. If you are giving normal saline to dextrose, if the patient's blood sugars are coming down but still ketosis is there, because your prime target is to stop ketogenesis, not to get the blood sugar down in diabetic ketoacidosis. And after 12 hours, usually this diabetic ketoacidosis is resolved by 12 hours if you manage it correctly. So after 12 hours, you have to look for the features of resolution and then change over to the subsequent management. So first hour management is get into a head in those parts. First one is ABCD, then you have to commence fluid. Fluid management in the first hour, if the patient is hemodynamically unstable, if the patient's blood pressure is less than 9 millimeter mercury, so then you have to give a 500 milliliters of normal saline bolus over 10 to 15 minutes. And then if blood pressure remains low, you can repeat another bolus over 15 minutes, 500 cc of normal saline, another over 15 minutes. And if blood pressure is still low, then you have to think of the other, like sepsis. Patients can come with MI and cardiogenic shock also. then the giving fluid is also a bit tricky. So in those conditions, you have to think of the other pump failures, that is heart failures and the other sepsis like conditions. And at the same time, in those conditions, you can use vasopressors like dopamine and noradrenaline if the initial fluid boluses are not the blood pressure is not responding to initial fluid boluses. If the patient's blood pressure is more than 90, then you can manage the patient with 1 liter of normal saline over first hour. And the other thing is this replacing potassium. It depends on the potassium level of the patient. If patient is having potassium of more than 5.5, you don't have to add potassium to your normal saline infusion. But if it's less than 5.5, that is in between 3.5 to 5.5, you have to add 40 millimoles at least, not at least actually, 40 millimoles of potassium chloride into 1 liter of fluid infused that you are giving. If you are giving the fluid as a bolus, then you don't have to add to the first one. If you are giving the fluid as a bolus, like in the first instance, over 10 to 15 minutes, you don't have to add potassium to that first liter of infused. But afterwards, you have to add this 40 millimoles per each liter. If it's less than 3.5, then before starting this insulin infusion, you may have to correct potassium. So that's the second one. Before commencing insulin, you have to see whether the patient is having potassium of more than 3.3. If it's more than 3.3, it's fine. You can go ahead with insulin. Insulin, what you are starting here is a fixed rate insulin infusion regime. The previously discussed that, as you saw in the previous lecture, it was a variable rate one. According to the blood sugar, it varies. But this one, we fix it because we want to inhibit the ketogenesis. We fix it. We are giving a fixed dose of 0.1 units per kilogram per hour. That is, if the patient whose weight is 60 kilograms, then we have to start at a rate of 6 units per hour. The infusion, this making of infusion is usually you get a 0.5 cc of this soluble insulin and at 49.5 cc of normal saline, and you make a 1 unit per milliliter infusion. So thereafter you start this insulin infusion with the fluid, and then you have to pre-check the patient's urine output as well as eGFR. If the patient's eGFR is less than 15 and urine output is not enough, more than 50 milliliters, then you must be cautious before adding this potassium as well. If the patient was on long-acting basal subcut insulin, that is insulin glargine, or sometimes this isopane insulin, you can continue the same doses subcut. So reassess the patient, and the earlier investigations, as I said, diagnostic investigations, first 3, the bedside point of care blood glucose assessment, as well as ketones and ABG for acidosis. Then you establish this monitoring regime, and then you go to the second hour. But in children, this 1 liter will not work because some children are really small, especially type 1 patients. So typical fluid deficit in children is 100 milliliters per kilogram. It depends on their degree of dehydration. In mildly dehydrated patients, they are having a 50 milliliters per kg deficit, and moderate 70 milliliters per kg, and severe 100 milliliters per kg. So all non-shock, that is blood pressure more than 90 patients, should receive a 10 milliliter per kg bolus in 60 minutes. And shock patients should, like in sepsis, they should receive 20 milliliters per kg IV normal saline over 15 minutes and reassess. Rest of the fluid management should be divided should be given over 24 to 48 hours, because in children there's a higher risk of getting a cerebral edema in fast fluid correction with the rapid changes in osmolality. So what you can do is you can give the bolus, then take this full deficit, reduce the initial bolus, and at the maintenance, hourly maintenance, at the 24-hour maintenance fluid to that, and divide it by 24 or 48 hours, and then give over 24 to 48 hours. So from 60 minutes to 6 hours and up to 12 hours, you have to see whether your goals are achieved. Your goals are, you have to get down the ketones as at least 0.5 millimoles per liter per hour. Or bicarbonate, if you are going by bicarbonate, it has to rise at least 3 millimoles per liter per hour. And blood sugar values should fall at least 3 millimoles per liter per hour, that is 50 to 60, 54 milligrams per deciliter per hour. If those targets are not achieved with your insulin, like if glucose doesn't fall by 50 to 60, you can increase the insulin infusion rate and adjust according to that. You should be cautious about the hypoglycemia, because sometimes blood sugar values will come down, but the patient will be still having this acidosis and ketosis. So in that case, to prevent hypoglycemia, when the blood sugar values comes down to 250 milligrams per deciliter, then apart from the fluid that you are giving, you have to add 125 milliliters per hour, 5% dextrose, some say 10% dextrose, and 10% dextrose, 125 milliliters per hour, apart from the fluid that you are giving, to prevent patient going into hypoglycemia while continuing the insulin infusion. Don't stop the insulin infusion until you get the resolution of diabetic ketoacidosis, that is until you stop the ketogenesis. That's one of the main messages that I want to give in with regards to diabetic ketoacidosis management. So and the other thing is, when blood sugars coming down to 250, you can reduce the ongoing insulin infusion rate, soluble insulin infusion rate, to half to prevent hypoglycemia as well. And the other one, in some guidelines, it says to decide on this fluid type according to the sodium values. If the patient is hyponatremic, or if you are giving a bolus, you can always use normal saline. If the patient is eunatremic or hypernatremic, you may use half normal saline as well with the same rate. So rates of infusion after the first hour, in next 2 hours you have to give 1 liter, and the next 2 hours also 1 liter, afterwards 1 liter over next 4 hours. So meanwhile you have to assess and manage the other ongoing sepsis and other conditions as well. This is also the same. You have to give fluids 1 liter over next 4 hours, and the same change to dextrose if the patient's blood sugar dropping less than 250 in the presence of ketosis, and reduce the insulin infusion rate if the patient's blood sugar is dropping and still ketosis is there, and maintain the blood glucose around 200 until the patient's ketosis resolves. So this is the same. By 12 hours you should achieve the resolution of diabetic ketoacidosis. But if you are not achieving the resolution, that is resolution of diabetic ketoacidosis, mainly if the capillary ketone levels should be less than 0.6 millimoles per liter, and pH should be more than 7.3, bicarbonate should be more than 18, and blood sugar should be less than 200. So if those resolution criteria are met by 12 hours, you can then change over to the other part, insulin regime. Otherwise, you have to think are there any pitfalls in your management, like sometimes insulin infusion pumps are not working, and insulin infusion this preparation is not correct, and sometimes even after the resolution of diabetic ketoacidosis, patient may continue to have this ketoacidosis because the acetoacetate is this beta hydroxybutyrate is converting into acetoacetate. And then the other one is sometimes with high fluid given normal saline, you get hyperchloremic metabolic acidosis as well. So in that case also you will have this persistent metabolic acidosis in the absence of diabetic ketoacidosis as well. So when the resolution criteria are met, you can change the patient into, if the patient is not taking adequately orally, you can change the patient to variable regime, that is variable dose insulin infusion regime. Or if the patient can take oral, this is very important because at the end of the resolution of DKA, diabetic ketoacidosis, most of the management ends there, and then they are directly converted to they are stopped. The infusions will be stopped, and the patient will develop again diabetic ketoacidosis in 6 hours. So what you should do is you have to calculate the total insulin infusion dose that you have given to manage this diabetic ketoacidosis over last 24 hours, and then divide it to 50-50. You can give 50% of that via basal insulin, either isopain insulin or glargine insulin, and 50% via bolus insulin, and one third of that 50% has to be given as a subcut soluble insulin injection, and then patient should be asked to eat, and after about 30 minutes to 1 hour you should stop the insulin infusion. Don't stop the insulin infusion just after giving subcut insulin, because subcut insulin takes time to act, and with meal patient's blood sugar will again go up and he will go into diabetic ketoacidosis again. If the patient was on insulin previously, you have to keep that same insulin dose, and you can adjust thereafter that with the response. So management of hyposmolar hyperglycemic state is not that much of a difference. Those are like one goose and one duck. So in the diabetic ketoacidosis, you have to stop the ketogenesis. In hyposmolar hyperglycemic state, you have to correct the dehydration. Those are the prime objectives. So management is more or less the same in both, especially in adults. It's same, and fluid management may be a bit aggressive, because in diabetic ketoacidosis, fluid deficit in adults is around 6 liters, but in hyposmolar hyperglycemic state it's around 7 to 9. So you may have to give some more fluids in those patients to correct the hyposmolarity. And the targets are also different. You don't have to worry about the ketogenesis. You have to achieve the serum osmolality level of less than 315, and you don't reduce the blood glucose levels that much, around 200, like in ketoacidosis. You have to get the blood glucose levels up to 250 to 300, and get down the serum osmolality less than 315, because drastic changes in osmolality will cause sudden electrolyte disturbances, as well as in children cerebral edema. In children, this fluid replacement, apart from the maintenance as well as this deficit, you have to replace the urinary losses, because when we are giving fluids, the patients who are dehydrated and hypovolemic will have a higher renal perfusion when we give fluids. With higher renal perfusion, with the hyposmolarity, hyperglycemia, the patients will have osmotic diuresis, profound osmotic diuresis as well. So that is taken as again a loss. So we have to replace that urinary losses as well. And the other one is, even with fluids in hyposmolar hyperglycemic states, the patient's blood sugar will go down. So you don't have to start insulin from the first instance. You have to correct the dehydration with fluids, and then you monitor the blood sugar drop. If it's dropping 50 to 60 milligrams per deciliter per hour, then insulin can wait. Then when the fluids are given, at the moment when the blood sugars are not dropping at that rate, then you introduce insulin to the regime. That also you have to introduce at a lower dose, because that will bring down the this osmolality fast if you start at a rate of 1 units per kilogram. So here we use a 0.025 or 0.05 units per kilogram per hour. And the deficits of electrolytes are also higher. You may have to think of phosphate and magnesium replacement as well. As I said earlier, in those two conditions, do not forget to manage these precipitating factors as well as complications. Especially in hyposmolar hyperglycemic states, patients will be dehydrated and hyposmolar. So there's a high risk of thrombosis and acute coronary venous and arterial thrombosis. So patients should receive prophylactic low molecular weight heparin. Small talk about this euglycemic diabetic ketoacidosis. Presentation in a patient who was recently started on SGLT2 inhibitors like empagliflozin, canagliflozin, or dapagliflozin, coming with unwellness for few days, and maybe patient who has undergone a surgery in the presence of SGLT2 inhibitors, because you have to omit SGLT2 inhibitors at least 2 to 3 days prior to the surgery. So when there's an stress like sepsis surgery in the presence of SGLT2 inhibitors, the patient will have unwellness. So then you have to think of this euglycemic diabetic ketoacidosis. Diagnostic criteria is not that much different from the diabetic ketoacidosis. The term euglycemic means their blood glucose is less than 200, but ketosis and acidosis will be there. Management is the same. You have to give fluids, omit SGLT2 inhibitors, and because already patients' blood sugar values are within the normal, like less than 200, you have to, when you are giving fluids, you have to give 5% dextrose in half normal saline to avoid hypoglycemia, and use lower dose of insulin infusion, like half dose which we are using in diabetic ketoacidosis. So your target is to stop ketogenesis while maintaining normal blood sugar. Hypoglycemia, I know that this maybe that at the moment it's an experience to you all, but identify the symptoms. I can see the symptoms actually, and then patients may be feeling hungry, yawning, dizzy, sleepy, and then palpitations, sweating, confusion, deteriorating level of consciousness, and then go into coma. So those are the sequence. You don't have to wait until the patient's going into the coma. So when the patients are having this hunger, yawning, sweating, you have to identify the symptoms and confirm by point of care blood glucose monitoring. If it's less than 70, then if the patient can take oral, you have to follow the 15-15 rule. That is 15 grams of carbohydrate has to be given, and after 15 minutes you have to check. 15 grams of carbohydrate usually consists in this tea with 1 to 2 teaspoons of blood sugar, and then 2 slices of bread, the 200 cc of milk, likewise. And if the patient is unconscious, fainting, or aggressive, if the patient is kept nil by mouth, you can't give orally. Then you have to go for 10% dextrose, 200 cc over 15 minutes, or 20% dextrose, 100 cc over 15 minutes. If the patient is not having an intravenous access, you may have to go for this IM 1 milligram of glucagon and recheck the patient after 15 minutes. If the patient's blood sugar is still less than 70, you can again repeat the same. But if the patient's blood sugar is more than 70, then always don't leave the patient without giving anything. Ask the patient to take 15 to 20 grams of long-acting carb diet. If the patient can take his usual meal, ask the patient to have his usual meal. Otherwise, milk and 1 to 2 slices of bread, or complex carbohydrate diet after this initial IV correction. Otherwise, with this IV correction, there will be rapid glucose surge in the blood, there will be high insulin surge in the blood, then they will be again going into hypoglycemia if you don't supplement it with complex carbohydrate. So in summary, diabetic ketoacidosis and hyposmolar hyperglycemic state, main management parts are fluid, insulin, electrolytes, precipitants, and treat the complications. Euglycemic diabetic ketoacidosis, always think when the patient is on SGLT2 inhibitors, main objective is to stop ketogenesis with insulin and fluid with dextrose. And in hypoglycemia, always try to avoid hypoglycemia in hospital setup and anticipate hypoglycemia, especially in lean, elderly, more than 65, CKD, CLCD patients, and be alert on the symptoms and confirm and treat with 15-15 rule of IV 20% 100 or 200 cc of 10% dextrose, followed by a concentrated carbohydrate diet. So that ends my diabetic emergency talk. Thank you. You can ask any questions if you have later. Yes.